Hi everyone, thanks for listening to my presentations. Today I'll continue as part of the series when it comes to hyperthyroidism is thyrotoxicosis. And this will form part 5 of 7. If you haven't listened to parts 1, 2, 3, and 4, please kindly do. Because with that, you'll be able to have complete picture when it comes to hyperthyroidism. Okay, today, thyrotoxicosis. Part 5 of 7. Let's go. Epidemiologically, thyrotoxicosis occurs in 1 to 2% of women and only in 0.1% of men. So more women are affected. Here, we are going to be dealing with excess T4 and T3. And expectedly so, they are below level of TSH. Here, we'll be dealing with a serious increased level of all metabolic activities. And that is why thyrotoxicosis is different from just any form of hyperthyroidism. Okay? Here, excess increase in metabolic activities, and the affected individual will become irritable. What are the possible causes? The common cause is hyperthyroidism, like I've said. And all causes of hyperthyroidism can actually cause thyrotoxicosis once it has tilted the individual to having excess or massively increased metabolic activities. It has become thyrotoxicosis. So it's not the problem of hypothyroidism if not given excessive exogenous levothyroxine while trying to treat hypothyroidism. So the problem is with hypothyroidism, okay, that has gone beyond usual range. So struma ovary could be responsible, and that is a rare ovarian tumor. And the tumor here will be made of thyroid tissue, can cause increased thyroid hormones. Still on causes, we might be dealing with autoimmune thyroiditis, particularly in smokers. That is not to say non-smokers cannot have autoimmune thyroiditis, particularly if they have other forms of autoimmune disease or diseases. But the probability is higher in smokers. It's possible toxic nodular goitre could be found, particularly in regions with decreased iodine, and the likelihood of it increasing with age is possible. It might be Graves' disease in women less than 40 years. You might be having toxic adenoma, which is a benign secreting thyroid tumor. It could be exogenous thyroid hormone, particularly in mental disorder and factitious disorder, individual deliberately creating the symptoms. In Graves' disease, if that is the cause, it is an autoimmune disorder. As a matter of fact, I have a separate presentation on Graves' disease. Please check my channel for that. Here, there will be thyroid-stimulating immunoglobulin that is going to bind to thyroid-stimulating hormone on the receptor cell membrane. And that will lead to excess synthesis and increased secretion of thyroid hormone, and it will also stimulate the thyroid-stimulating hormone receptor. In toxic nodular goitre, which is a benign monoclonal thyroid tumor, it will autonomously be secreting excess thyroid hormones. It can be a single nodule or a multinodular goitre. When it is multinodular, it is known as toxic multinodular goitre or plumar disease. It could be thyroiditis. In that case, there will be decreased radioiodine uptake. Might be painless with lymphocytic thyroiditis or occurring in postpartum as postpartum thyroiditis. The inflammatory process here would destroy the thyroid gland. Still on thyroiditis, there will be transient mild thyrotoxicosis from the released hormones. After sending the stored hormones into the circulatory system, hypothyroidism will follow. There is the probability or the possibility of normal functioning gland in 80% of affected people after the cessation of the inflammation, and that is expected to occur within 1 to 2 years after the inflammatory process. In subacute thyroiditis, we'll be dealing with increased erythrocyte sedimentation rate or C-reactive protein. It's going to be painful, and the pain will be found at the anterior neck. Is the commonest cause of thyroid pain. Note that. Subacute thyroiditis. It could be caused by virus, but one good thing about this is it is self-limiting. Still on subacute thyroiditis, the clinical features here will include acute fever with severe neck pain. Remember, I've just said that the commonest cause of thyroid neck pain is subacute thyroiditis. There will be clinical features of thyrotoxicosis first, and after depleting the thyroid hormones in the thyroid gland, there will be hypothyroidism later on. After a while, there will be return to normalcy and increased CSR and C-reactive protein when you assay them. There is likelihood of exogenous ingestion of thyroid hormone causing thyrotoxicosis. This will occur sometimes while treating hypothyroidism with levothyroxine, that is a T4. There can be thyrotoxicosis from excess dose. It's either the dosage is high or the affected individual has taken more than the required amount within the required frequency. Maybe instead of once daily, the individual has taken twice daily, or the doctor has actually prescribed excess dosage from the onset. It may be inadvertently so, and that will be iatrogenic, or maybe intentional. T4 given to suppress thyroid-stimulating hormone in thyroid cancer or thyroid-stimulating hormone to decrease the size can also give this. There's likelihood of accidental ingestion. So all these scenarios could lead to thyrotoxicosis, and they are collectively known as exogenous ingestion of thyroid hormone. Factitious ingestion. This is a case where the individual is consciously taking tyrosine in factitious mental disorder. Factitious ingestion, we have a serum thyroglobulin values that are either very low or undetectable. Let me repeat. How are you going to be sure this is not something else? Okay, factitious ingestion will lead you to have serum thyroglobulin values assay, and you are going to get a result that will be either very low or undetectable. But in all other causes of thyrotoxicosis, serum thyroglobulin will be raised. Clinical features, generally speaking, because I'll still go over all the different causes later on, you can get all the general features of thyrotoxicosis when you check my presentation on hyperthyroidism. So check the clinical features of hyperthyroidism. All will play into the clinical features of thyrotoxicosis, and the metabolic activities there will be higher. So I'm not going to waste your time going over all of them right now, because that will take a long period of time. Kindly check out clinical features of hyperthyroidism. Diagnosis. Okay, somebody is asking, why talking about diagnosis once we've known it's thyrotoxicosis? Okay, wait. Do you know the difference between overt thyrotoxicosis and subclinical thyrotoxicosis? Don't worry, we'll get into that in a bit. How about toxic nodular goitre, Graves' disease, autoimmune, or thyroiditis? Let's see how we're going to make the diagnosis that will differentiate all this. In overt thyrotoxicosis, we'll be dealing with decreased thyroid stimulating hormone, but increased T4, increased T3. In overt hyperthyroidism, we'll be dealing with increased or normal radioactive uptake. In subclinical thyrotoxicosis, there will be decreased TSH, normal T4, normal T3. Thyroid radioiodine uptake. It will be raised in Graves' disease, normal or raised in toxic multinodular goitre. It will be low or undetectable in exogenous cause of thyrotoxicosis. It will be low or undetectable also in thyroiditis at the thyrotoxic phase. Scan. There will be diffuse uptake in Graves' disease. And of course, you will find only focal area of uptake when it comes to toxic multinodular goitre. Still on diagnosis, thyroid stimulating immunoglobulin will be at increased site when the cause is Graves' disease. TSI will be high in Graves' disease. Still on diagnosis, there will be increased thyroperoxidase antibody in autoimmune cause. So when you pick ITPO antibody, then have the guess that you are dealing with autoimmune condition. How do we treat? We will use anti-thyroid drugs. Don't worry, don't be in a haste, I will go over each of them. Radioactive iodine therapy, thyroidectomy, beta blockers, and of course, change in lifestyle. Okay, still part of the treatment is this clarification. When it comes to beta blockers, please, uses, contraindications, examples of beta blockers, all could be found in another presentation here on my channel. And that will be, if you check the treatment of hyperthyroidism, you are going to find all this there. There I've explained what beta blockers will do, that is, handling adrenergic symptoms like palpitation, tachycardia, tremor, heat intolerance. And I have stated contraindications like sick sinus syndrome found in elderly people because the sinoatrial node will experience degeneration when we become old. And bradycardia, you can't give it, and so on and so forth. I've also given examples where if a patient is having asthma or COPD, you cannot use non-selective beta blockers. In that wise, you will use beta-1 selective, like metoprolol or atenolol. I've given those details. And when it comes to lifestyle modification as well, you are going to find that if you check my channel on treatment of hyperthyroidism, that is also included there. So without wasting your time further, let's attend to other interventions here. Okay, delving deeper into anti-thyroid drugs, specifically thionamides. Thionamides include propylthiouracil, metimazole, which is very common in North America. So if you are practicing in the United States, Canada, and Mexico. You'll be familiar with this. And carbimazole if you're in Europe or Asia. Delving deeper into Thyroid, carbimazole is metabolized to metimazole, while propyltyrosine will decrease the conversion of T4 to T3. Metimazole is one daily dose medication, while propyltyrosine is multiple doses on daily basis. With that, compliance is higher with metimazole when you compare that to propyltyrosine. But those will sometimes have their days. Propyltyrosine is the only drug of choice in pregnancy and lactating mothers, where metimazole is contraindicated. And in pregnancy, you can only have surgery or propyltyrosine with beta blockers in hyperthyroidism during pregnancy, where metimazole is absolutely contraindicated. Still on treatment, glucocorticoids could relieve the anterior neck pain in thyroiditis. And glucocorticoids could also inhibit the conversion of T4 to active T3 in thyroid. Don't be in a haste. After this very presentation, I'll publish a complete lecture on thyroid. Please kindly watch out for that. Also, inorganic iodine like SSKI or Lugol solution could be very useful. It can decrease the synthesis of thyroid hormone and the release of the same. It's useful in thyroid storm or pre-thyroidectomy. In other words, while planning to have thyroid surgery, you can apply Lugol solution. Alpanic acid is useful here as oral cholecystographic agent, very rich in iodine, decreases synthesis and release of thyroid hormone, and can inhibit conversion of T4 to T3. For short-term use in thyroid storm, with rapid preparation for thyroidectomy, you can use that, but it is not effective as a long-term therapy. Let me repeat. With all these good qualities as far as handling thyrotoxicosis, is useful only for short-term purpose when you are dealing with thyroid storm, or when you are in a haste to prepare for thyroidectomy, you can use alpanic acid. But remember, this is not what we are going to prescribe for a long-term purpose. Radioactive iodine, 131 iodine, useful in Graves' disease, also in toxic nodular goitre. Within 8 weeks, there's likelihood of achieving euthyroidism in 85%. Only few doses will be required here. It will reduce the thyroid size by about 40% in toxic multinodular goitre. But be watchful. It can lead to hypothyroidism. Side effects of radioactive iodine: radiation thyroiditis, anterior neck pain, and note this, initial worsening of thyrotoxicosis will be experienced. Therefore, it will be wise to have pretreatment with thionamides, and that will prevent the worsening of the thyrotoxicosis. But remember, we cannot give radioactive iodine in pregnancy. Propyltyrosine is not good with 131 iodine. Instead, you can use metimazole or carbimazole for 3 to 5 days before the administration of 131 iodine. But propyltyrosine is good in pregnant women. Radioactive iodine is absolutely contraindicated in pregnant women. The same, if you are going to administer radioactive therapy to any other patient that is not pregnant and not lactating, use methimazole or carbimazole depending on whether you are in US or Europe or Asia 3 to 5 days before the administration of the radioactive iodine. Still on side effects of 131 iodine, there is likelihood of grace of thermopathy that could become worsened, and that will happen in smokers and those with severe hyperthyroidism. Okay, 131 iodine is relatively contraindicated in children. So a child with thyrotoxicosis with hyperthyroidism, no radioactive iodine, relatively, if you weigh other factors. The same with adolescent. But 131 iodide is absolutely contraindicated in pregnancy and lactation. Please and please. Absolutely contraindicated in pregnancy and lactation. Propita is okay in pregnancy and lactation and surgery. Of course, lifestyle modification and some other interventions like beta blockers. Okay, if you are dealing with thyroiditis, there will be decreased radioactive iodine uptake. Here, you can use beta blockers and glucocorticoids. Thyroidectomy will be welcome because it's going to cure the situation in about 90% of cases. It will decrease pressure effects of goitre. And if you are dealing with a pregnant woman, you can only have thyroidectomy in second trimester. There's likelihood of damage to recurrent laryngeal nerve, presenting with hoarseness of voice. There may be permanent hypoparathyroidism in about 1 to 2% of patients, and hypocalcemia will ensue for a while, and of course, there is likelihood of bleeding. There may be infection post-surgery and permanent hypothyroidism in many patients with thyroidectomy. The leakage of thyroid hormone into the circulatory system during surgery can actually trigger severe thyrotoxicosis. You can use cellnamines before the surgery to achieve euthyroidism. SSKI or Luger solution for 10 days before surgery is okay, particularly in Graves' disease, to decrease thyroid vascularity. In subclinical thyrotoxicosis, you might be dealing with some controversies because subclinical thyrotoxicosis treatment is subjective. Okay, you will be sure you are dealing with subclinical thyrotoxicosis with the following characteristics. There will be decreased thyroid stimulating hormone less than 0.1 milli international unit per liter. If that is the case, that warrants treatment. Let me repeat. You are dealing with subclinical thyrotoxicosis because the thyroid function test is pointing to that with some clinical features, but not so serious like overt thyrotoxicosis. But the thyroid stimulating hormone level is showing you that it's less than 0.1 milli international unit per liter. Please, that warrants treatment. Because if you treat at that level, that would decrease the possibility of atrial fibrillation. Okay? And it will also decrease the probability of osteoporosis in postmenopausal women. But if you choose to treat, please continue to measure thyroid stimulating hormone while on treatment. Stop your treatment when the thyroid stimulating hormone is within the normal range. Because, like I said initially, that when it comes to subclinical thyrotoxicosis, there are a lot of controversies. Some will choose to treat, others will not. If you choose to treat, continue measuring thyroid-stimulating hormone while on treatment, and once the value is within the normal range, stop the treatment. You may choose thionamines, but use low doses. Never use radioactive iodine. Don't use 131 iodine. You don't need that here. And with that, I've come to the end of this presentation. Please remember to share and subscribe. The next presentation will be about thyroid storm, and that will form part 6 of 7. Thanks, and I appreciate it.